This section is on thoracic surgery and laryngectomy. And as we start this segment, we're going to start off with a question. An adult client had a pneumonectomy and has returned to the nursing care unit. Which of the following is the most important assessment for the nurse to make? 1. Observe the tracheal position. 2. Auscultate bilateral breath sounds. 3. Monitor the arterial blood pressure. Or 4. Assess for bloodstreak sputum. And the correct answer is number 1. Observe the tracheal position. Now note that the patient had a pneumonectomy. What is that? That's the removal of one entire lung. So bilateral breath sounds are not going to be a high priority. I know a lot of you thought that was the right answer, but when an entire lung is removed, bilateral breath sounds are not the priority. But you do want to observe the tracheal position, and you're observing it for something called mediastinal shift. Now, mediastinal shift can sometimes occur following a pneumonectomy. If we look at this picture, this white part in here where the arrow is, this is the empty lung. This is where the lung was removed. I want you to note the structures here. Here's the trachea is up here. Notice how it's right in the center in the midline. Notice that the heart, where it's positioned here right in the center of the thoracic cavity. Note how much lung of the remaining lung is, how much of this, how much space between the heart and the chest wall. Now the patient who has had a pneumonectomy will not have chest drainage or chest tubes in place because there is no lung left to reinflate. However, there will be some air in the thoracic cavity from surgery. Occasionally, this doesn't happen all the time, but occasionally this pressure will be great enough to push the heart and the mediastinal organs here over to the side. Now look how close the heart is now to the chest wall on this side, how it's really squishing up that lung. Look at the tracheal deviation up here. You see how that trachea is curved. It's deviated or curved. And this is what we call mediastinal shift, and that tracheal deviation is what you're looking for. And this can occur in patients who have had a pneumonectomy. Now, if we think about how we would position a patient who has had a pneumonectomy, years ago we used to position them on the affected side. And if you look at the picture, that makes sense. If you put them on the affected side, then that would prevent the mediastinal shift. The only problem is, if you look right up here, then you know where this pulmonary artery is. You can see the pulmonary artery goes out, and here this would connect to the lung. Well, that has to be cut off. So there's a stump right there where that pulmonary artery used to be. And until that's healed, there is a risk of hemorrhage at that pulmonary artery stump. So we no longer put patients on the affected side. We can't put them on the unaffected side because that would cause mediastinal shift. So we usually position them in a semi to high Fowler's position. So that is a semi-sitting to an upright position, but not far on either side. Possibly a small pillow, just enough to get a little pressure off the area, but not up onto either side. Let's do another question. An adult had a right lower lobectomy. When he returns to the surgical unit, the nurse places him in a semi-sitting position on his left side. What is the primary reason for placing the client in this position? 1, the client will have less pain. 2, there is greater expansion of the operative lung. 3, the nurse is better able to assess for hemorrhage. Or 4, this position will help to prevent the development of shoulder ankylosis. And the correct answer here is number 2. There is greater expansion of the operative lung. So with a right lower lobectomy, only one lobe of the lung has been removed. Remember, the right lung has 3 lobes and the left lung has 2 lobes. So one lobe has been removed. In that case, you would put him on the unaffected side, and then you would put them in a semi-Fowler's type position, allowing greater expansion. Now, I did want to mention that question had the word ankylosis in it. I want you to think about, what does ankylosis mean? It's right down there on that last question. The development of shoulder ankylosis. Ankylosis, if you were to look that up, means crooked or growing together. So in a patient with shoulder ankylosis, that's called frozen shoulder. That is a risk. That's a postoperative complication for people who have had thoracotomies or thoracic surgery. The way to prevent that is range of motion exercises. We usually start with passive on day of surgery, and then in the next day or two we start with active exercises. I want us to think about laryngectomies. So if we take a look at this picture here, you can see the larynx right there. That red thing right in there is the larynx, or the voice box. Now normally the air will, when you're speaking, air goes up, and then your vocal cords move and you can make speech sounds. I want you to notice also right here above that area, but right in there where that arrow is moving, is where your epiglottis is. The epiglottis is a little flap, and that little flap goes over your trachea, back and forth, back and forth, back and forth. It just sits over your trachea and moves back and forth, kind of just back and forth, so that when you're speaking or breathing, it opens, and when you're eating or swallowing, it closes. So it opens for speaking and breathing and closes for swallowing. And so it keeps moving back and forth. And I want you to notice that. You know, sometimes if it doesn't keep up with what you're doing, you sometimes have, when you were trying to talk and laugh, drink and talk at the same time, that it sometimes goes down the wrong way. But that's the epiglottis. All right, now, if we're going to talk about a laryngectomy, laryngectomies are most commonly done for patients who have lung cancer. It's possible to do partial laryngectomies. With a partial laryngectomy, what we would see is the patient would have part of their voice box removed, then they'll be on voice rest for several weeks, and then they'll be able to speak again, but probably with a raspy voice. NCLEX is more apt to ask you questions about total things. So we're going to focus most of our attention on a total laryngectomy. So if we look at the picture over here, you can see that the whole larynx, this part here, is gone. So the whole larynx has been removed, and what remains of the trachea is now pulled and attached to the neck. So there's a stoma made at the neck, an opening there, and the trachea is attached there. There is then no need for this epiglottis anymore. So that area is a little surgical intervention in there to close off the epiglottis. Now, in the immediate postoperative period, the patient may have a nasogastric tube just until that area right up in there heals. Once that's healed, they'll be able to swallow and eat normally. Now, notice here on the picture that the only way for air to get into the lungs is through the stoma. There is now no connection between the nose and mouth and the lungs. So the only air that gets into the lungs comes in through the stoma. So that means that you can never completely occlude that stoma, can't completely block it off ever, or the patient won't breathe. All right, now, a couple things we want to think about. How does this patient talk? He has no voice box, so how will he talk? Well, he's not going to talk normally again. In the very immediate post-op period, we don't expect any type of verbal communication. We would either ask the patient to write, use pencil and paper if they were literate, and could write a language that you could read. You could set up a signal system so that they could do a signal of foot movements perhaps. I don't think I'd use head movements in someone that just had a laryngectomy, and frequently they have a radical neck dissection that goes with that. So I don't think I'd use head movements for that patient. In the long term, the patient has a couple of choices for verbal communication. One is a device, about the size of this little slide changer that I have here. And the patient will put this up against the neck region. It sounds like that. It's kind of a buzzy, backgroundy noise, and the patient then speaks to kind of interrupt that buzzy kind of noise. That's really hard to learn how to listen to because it takes definitely acquiring an ear for it. But the patients can learn to communicate that way, and the people around them can learn to understand that. There's another option as well, and for that option we look back at that picture. If we look back at that picture, what the patient does is swallow air and talk on a burp. So they swallow air, all these little red arrows here, they swallow air through the nose or mouth, goes down into the stomach, and then it comes back up and they talk on a burp. They sometimes call this esophageal speech or plosive speech. So they really learn how to move their tongue against the roof of their mouth, move some of the esophagus muscles, and they begin to learn how to speak, literally talk on a burp. Isn't that fascinating? They can learn to talk on a burp, and some get very, very good at that. We don't have to teach them how. That's the job of the speech therapist. Our job is to make sure that they get the referral to the speech therapist, so make sure that they've had that referral. Another thing that might come up in the care of a patient who's had a laryngectomy, and that is there might be a question about what kind of safety concerns would be really important. And what we might be concerned about is smoke detectors in the patient's home. The patient no longer breathes through their nose, so they could not smell smoke. So they need a smoke detector. That would make a very good safety question on NCLEX, so making sure that their home is equipped with a smoke detector. Would it be better for this patient who has had a laryngectomy to take a shower bath, a shower, or a tub bath? A tub bath would probably be safer. Most tubs, you don't have water up to here, but if you're in the shower, water could easily go down your stoma. There are actually available some deflectors that would deflect the water. If the patient had that, then a shower bath might be safe. Are there any sports that a patient who's had a laryngectomy should not engage in? Yeah, swimming would be a bad one for this patient. No swimming, no boating, no water skiing. And one more question. The nurse is caring for a patient who is scheduled for total laryngectomy tomorrow. Which action is essential? 1, determine if the patient smokes. 2, determine if the patient can read and write. 3, explain how patient-controlled analgesia works. Or 4, describe esophageal speech. Now, all of these may have some relevance, but the one that is most essential is answer number 2. Determine if the patient can read and write, because in the immediate postoperative period, your communication is likely to be written communication if they can write a language that you can read.